Hi again everyone, and in this second part of the renal physiology we are going to cover mainly the countercurrent multiplication, which is a process found at the loop of Henle level. In addition to that, we will talk briefly about the role of urea as well as the sodium that got reabsorbed in creating this countercurrent multiplication, and from there we will finish with discussing briefly the antidiuretic hormone, also known as arginine vasopressin hormone, which is a hormone from your hypothalamus that is regulating the amount of water that you will be losing in your urine through altering the structures of the water canals found in the collecting duct, and therefore you have more what we call aquaporins. Those aquaporins will allow you to reacquire large amount of water that you lost through the filtration process. This is one of those places where the water level and the water loss can be managed. Unlike all what we learned earlier, all the water that we were able to reabsorb, these were volumes that we had no control over. But when it comes to the antidiuretic hormone, that is the main part where we can manipulate. In addition to that, we also have the aldosterone, which reabsorbs sodium also at the distal level, not at the proximal and not at the loop of Henle, and it allows you to retain sodium, and when you retain sodium, then consequently you are also retaining water. Anyhow, let's begin with talking about the urine excretion and the countercurrent multiplication, which we covered at the lecture. The osmotic pressure, the vertical osmotic pressure in the kidney can be established, and it goes from the cortex all the way down deep to the medulla to approximately 1200 milliosmoles per liter. And that's fairly high osmotic pressure, and that's very, very important in creating highly concentrated urine. For example, in situations where you have not been drinking enough water, and you do need to retain the water from your urine, and you don't want to rely entirely on your antidiuretic hormone to do so. So if we look at the osmolarity of your kidney, you will see that from out inward you have an increase in the osmotic pressure. And we will talk about these factors and why do we have this kind of increase, which is aided by glomeruli that are found here, which we call juxtamedullary nephrons, not the glomeruli, but the nephrons that are found here near to the medulla, and they extend the loop of Henle all the way down to allow you to create this concentrated urine. So a gentle reminder for you to demonstrate the differences between the cortical nephrons and the juxtamedullary nephrons. The juxtamedullary nephrons are the ones penetrating way deep in the medulla, and those are really the ones we will be talking about. So although we do have countercurrent multiplication, the high numbers you will see, we are referring in it to the juxtamedullary nephrons. Does it mean that the countercurrent multiplication is not present in the cortical nephrons? By all means, no. It does exist. However, just the osmotic pressure here does not rise to the same levels we see here with the juxtamedullary nephrons. So both of them are working the same effect, kind of. Just the difference here, as you will see in a short bit, that the osmotic pressure inside those loops is significantly higher as they descend deeper into the medulla. But what causes this to happen? I'm going to skip through the text, and I hope that you will have the chance to read this text in your review, but I'm going to review the process with the following slides. And let's talk about the loop of Henle. It's as segments wise. So we have the upper portion, or portions that will not descend all the way. If we have a loop that is not descending all the way into the medulla, they start all by having osmotic pressure that's about 300 inside and outside. And because the ascending loop is reabsorbing the salt, it's going to start dumping the salt into this space. As you can see here, we have the sodium chloride being dumped into that space here, aided by the sodium-potassium pump that's found here, which dumps the sodium, and consequently you are taking away sodium from this space. And when you did that, when you took sodium from here, that of course impacted your osmotic pressure here, and as you can see, that dipped down because you removed the solute out of it. As a consequence of having sodium chloride here, the water will start filtrating through the descending limb of your nephron loop, or loop of Henle. And by losing water, then your descending limb will start to have higher solute concentration, and therefore you have higher osmotic pressure. And if we move from that to the next step, whether we are talking within the same loop or we are talking about another loop that extends deeper into the medulla, but it just happened to be next to it, so it will be affected by the same salt concentration that is here in the interstitial space. Whichever the reason is, you will start to dump more salt into the interstitial space, and the more salt will attract again more water. So now we're talking about higher osmotic pressure in the descending limb. And from there you can even go higher. Now you have more salt being dumped, and then that will attract more water. Once again, more salt being dumped, more water will be attracted. You can end up having a 1200, and remember our starting point was 300 that we began with, and the deeper you go into the medulla, the higher the osmotic pressure will go. But then on the ascending limb, you are reclaiming some of the salt, the sodium chloride, and therefore you can see that your osmotic pressure is falling down. What we see here is called countercurrent multiplication, in which one arm impacted the other arm by dumping in the sodium chloride in the interstitial space, and therefore you have the water being dumped into the interstitial space as well. And because you are dumping the water there, then the osmotic pressure of the incoming solution will be high, and therefore what it means is the sodium chloride concentration, the relative sodium chloride concentration here is high because you just lost water in the descending limb. And when you lose the water, you have high sodium chloride concentration, and therefore it will be much easier to dump that excess amount of sodium chloride into the interstitial space. What helps it even further is the presence of blood vessels, whether it's the peritubural blood vessels or capillaries or the vasa recta, and these will start removing immediately the sodium chloride and the water away from here. But because the vasa recta can go all the way down to the medulla, as far as or even deeper than as the juxtamedullary nephron go, the osmotic pressure inside the vasa recta will also be elevated as a consequence, and therefore the vasa recta themselves, they also help you in the process of making the concentrated urine. Now, that was the countercurrent multiplication, and I think it's a very interesting phenomenon, and we have explained it in greater details during our lectures. How does it occur, and what guides it, and mainly the sodium chloride. But as you will realize later on, that we have another solute that will be excreted from your collecting ducts, which is the urea, and dumping the urea in the interstitial space there also will create higher osmotic pressure inside the interstitial space, and that will guide also in the reabsorption or the reclaiming of the water as it descends through the descending loop or the descending limb of the loop of Henle. So yes, the sodium chloride is participating here, but as you will see in a short bit, the urea is also participating. We ended up having little sodium chloride because a lot of the sodium chloride will be reclaimed at this point, but we still have some sodium chloride, and that will be reclaimed by the aldosterone help later on, as you will see in the next chapter. But at this point also I would like to emphasize that we still have tons of water, about 15 liters or so, that you still need to reclaim, and there the help would be of the vasopressin. Now the vasopressin is a hormone, has another name, which is arginine vasopressin, or also known as antidiuretic hormone. It's produced in the hypothalamus, and it will be stored temporarily in the posterior pituitary till you need it. Now the vasopressin will work on the tubular cells, on the collecting ducts, and through a cyclic AMP mechanism, and will start allowing more aquaporins, which are the channels for water, to be available, and therefore it will help you reclaiming the water. So if we look at the mechanism here what happens, the vasopressin is coming through the blood, and it will bind to a specific receptor found on the cells that are in the principal cells, which are in the collecting ducts. And once it goes there, it will stimulate cyclic AMP production, and the cyclic AMP production will allow those aquaporins not to be expressed, but just to be translocated into the membrane, and therefore allowing the water to flow in. And when the water accumulates inside the cell, it will also flow outside, because remember, we have here a high osmotic pressure outside in the interstitial space, and that will allow the water also to pass through. So this is the function of the antidiuretic hormone, and without it we have a clinical situation called diabetes insipidus, where the patient keeps drinking water, a lot of water, to replace the 15 liters of water or so he's losing daily as urine, because of the absence of the vasopressin or the antidiuretic hormone. Antidiuretic hormone can be also inhibited by alcohol, and therefore people who are intoxicated with alcohol, they form more urine amount, and that's because of the inhibition of the vasopressin production. That is very different from using diuretics, which are either osmotic diuretics or diuretics that will inhibit the reabsorption of sodium from your tubules, and therefore when sodium stays in the tubules, then it will attract water to it, and by those means you will have diuresis. But it's a different mechanism of diuresis than the one here, as I explained, with that is concerning alcohol. Here's another picture for the arginine vasopressin mechanism, or the antidiuretic hormone. Again, it binds to a receptor. It will activate the release of cyclic AMP through adenylyl cyclase, or G protein first, and then adenylyl cyclase. That will activate certain pathways, and when you activate that, it would allow the aquaporins to translocate, and therefore now you have the aquaporins on the surface allowing you to reclaim the water. So in the presence of in the presence of antidiuretic hormone, it will allow you to reclaim the water, and therefore you are producing concentrated urine. In the absence of antidiuretic hormone, let's say you have been drinking a lot and you have too much water to lose, and you want to lose that amount of water, so you will not have enough antidiuretic hormone, and therefore there is no reclaiming of the water at this stage. So whatever you are producing here, it will just go through without any further modification water-wise, and therefore you are producing large amount of diluted urine. So these are the differences between the presence, the formation of urine in the presence of antidiuretic hormone and the presence of urine in the absence. As you can see here, they even painted it dark yellow for you, indicating that this is concentrated urine, whereas here we have a light yellow urine. Again, this is the countercurrent multiplication we talked about earlier, but now I embedded in the effect of the antidiuretic hormone and how it reclaims the water at the collecting duct level. And as you can see, at the collecting duct level also I'm reclaiming the urea, and if you remember earlier, I told you that the urea is going to cause the osmotic pressure of the interstitial space to rise, and therefore it will impact your ability to reabsorb water from your descending limb as well. And significantly also the vasa recta, which is going deep as well into your medulla, and it will be affected, the osmotic pressure in it will be affected similarly as it goes into the medulla. But as you can see also here, that the osmotic pressure that came in was 300 and the one that came out was 320, even though that this now is located in the cortex, which generally has low osmotic pressure. But just the presence of capillaries that are carrying 320 instead of 300 will also influence the osmotic pressure in the adrenal cortex, and therefore it can help in forming much concentrated urine for you. Okay, so this is a nice summary, and I would encourage you to use this summary in your study guide to summarize the chapter, what gets filtrated at the glomerular level and what gets reabsorbed at the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and both in the late, there is early convoluted tubule and late convoluted tubule, which gets very similar then to the collecting duct, and what gets absorbed at the collecting duct. And here again another summary slide for what gets reabsorbed and how is that impacting your osmotic pressure, and the reclaiming of urea here, as I told you, happens at the collecting duct, and as I told you, it does influence indeed the osmotic pressure of the interstitial space, and therefore allowing you to form a concentrated urine. And as I told you in the lecture, people who are not eating enough proteins, they don't generate enough nitrogenous waste, and they have hard time in producing concentrated urine because of the fact that they don't have the colloidal pressure that allows them to regain the water back, and they also don't have the urea to be secreted or excreted into the interstitial, or reabsorbed, I'm sorry, into the interstitial space. And if you have about 40% or so left here in the interstitial space, that will indeed impact the osmotic pressure, but in the absence of nitrogenous waste, you will not be able to do so. Therefore, people who are in a strict diet or malnourished, they also produce a lot of urine, and which can result in losing very valuable minerals as well. Okay, so here's another summary slide for the entire action that's going on in the tubules and the reclaiming of the water and the salts. We will cover still the balance in the water, in the sodium chloride, the sodium, the chloride, the potassium, the calcium, the phosphate, and the hydrogen ions, and the carbonate ion, when we get into the next chapter, which deals with acid-base, electrolyte, and water balance mechanisms. So we'll skip through the calcium reabsorption because, like I said, we are going to cover that when we get into the into our next chapter. But for now, just for short, 100% of the free calcium, not the one that's bound to proteins, will be filtrated here. And then when it passes through the proximal convoluted tubule, you will end up only with 40%. And by the time it passes through the loop of Henle, now you have only 10% of the calcium being still left. And then you will be playing with about 5% in the collecting duct, which can be reabsorbed by the cells here in the collecting duct, that will allow you to reclaim some of that calcium back. And we will talk about those cells, the intercalated cells, and how they are affected by a hormone called parathyroid hormone to reclaim also part of your calcium back. Renal failure is not a disease, it's a consequence of something, whether it's an infection, toxic agent, autoimmune disease, whatever the reason is. You have inadequacy of the urine function, whether to excrete certain toxic metabolites or excrete potassium, excrete hydrogen ions. All of that can be falling under the umbrella of renal failure. And we have a famous story of renal failure being caused by bacteria that is found in the that are E. coli, and it's found in uncooked meat. And when it gets into the body, then you have these bacteria secreting a toxin, the Shiga toxin, and the Shiga toxin can destroy the proximal part of the tubules, the proximal convoluted tubules, and that can result in, and also the glomerular filtration membrane, that can result in proteins and blood cells to enter the urine, and that is a serious situation, of course. So we don't have to cover this, since this is not an internal medicine lecture, what happens when a person has renal failure. But if you think of it, you know, since the kidneys can excrete certain metabolites, then toxic metabolites, then you have a retention of urea, you have the retention also of ammonia. You have acidosis because the kidney is supposed to get rid of hydrogen ions, then you have metabolic acidosis. Potassium is supposed to be actively excreted out of your kidney, and when you don't have that, then you will have a high potassium retention. You will have sodium imbalances because you are losing sodium in the kidney and you don't have the ability to regulate that. You can also have phosphate and calcium imbalance, and if the filtration membrane now is being compromised, you can start losing plasma proteins, because if you remember, we said that the plasma filtration membrane, or the glomerular filtration membrane, is fairly small and it allows only molecules less than 3 nanometers. But if you start going with damage, then it will allow proteins to pass through and even cells to go through. You can start with a renal failure because of the retention of water, or whatever the reason is. You can start suffering from hypertension, anemia, that's caused by whether the loss of proteins, or it's because of the fact that you're not making enough erythropoietin. Remember, the erythropoietin was the hormone made by the kidney to stimulate the red blood cell production. So these are things that can happen with the renal failure and complication of renal failure. Finally, the passage of urine. The urine is supposed to be urination is supposed to be stimulated by stretch reflex that's built in your urinary bladder. And of course, we are inhibiting that mechanism by sympathetic nerve fibers, which also close the sphincters down, and that allows you to hold on the urine for the right time. And this, of course, can be damaged, and in patients with paraplegia, and or in situations where the muscle support, part of the urination process is not just sympathetic and parasympathetic. It's not only automated, but it's also inhibited by your conscious nervous system, the somatic nervous system. We have muscles that can act as sphincters, and any damage to that muscle or to the nerve that supply those muscles will allow the person, or will cause the person, to leak urine, and we call that urinary incontinence. It's a more common situation in female because of the wider urethra, and also because of the labor process, which tends to damage some of the muscles in the perineum, and therefore it's more common to have urinary incontinence. But of course with males as well, then, as we discussed in the lecture, especially if they undergo prostatectomy, that can result into urinary incontinence as well. So that summarizes the second part of our urinary system. The first part was much bigger, of course, because we talked about the glomerular filtration, we talked about the renin-angiotensin system and the aldosterone system. We discussed together the renal reabsorption and the renal excretion of substances, and the tubular maximum, and why is it patients with diabetes tend to lose sugar or glucose in their urine, and why do they have a higher urinary urine volume than normal individuals. And in the second part we mainly focused on two things. We focused on the countercurrent multiplication, and then we talked once again about the arginine vasopressin system, and I showed you the importance of the urea in your urine formation and creating high osmotic pressure in the interstitial space. So that was my summary to you. I hope you find it useful for your review. Please don't rely just on these review slides. I would like you to read the chapter. Don't rely just on my slides as the only source. This is just a review part, and I hope you will find that useful. And join me again for the next lecture, where we will cover the acid-base, electrolyte, and water balance. Have a good day.